Welcome, everyone. We're going to get started. If you can grab your food and have a seat. Just a reminder, as you are getting seated and situated, for questions to be submitted, please scan the QR code. We will be looking at them live and answering your questions at different intervals over the next hour or so. And this can be done from your personal device. You can also access slides. Okay, so the topic for today is an exciting one. We are going to be talking about revolutionizing heart failure management with a focus on nonsteroidal mineralocorticoid receptor antagonists. Heart failure continues to challenge us. It's one of the most common and leading causes of hospitalizations and morbidity worldwide. Despite advances in medical therapy and device-based therapy, we know that outcomes remain poor. Despite us knowing that we need to block the renin-angiotensin-aldosterone system, and we've known the importance of, in particular, blocking the mineralocorticoid receptor, drugs like spironolactone and eplerenone have had limited uptake. And the reason it includes hyperkalemia, worsening renal function, and oftentimes off-target hormonal side effects. One of the most exciting aspects, I think, of our field at the present moment is the fact that we've shifted our framework from heart failure and focused on just heart function, ejection fraction, et cetera, to a broader outlook that's really encompassed in this cardio-kidney metabolic framework, where we're recognizing the importance and the interconnectedness of systems, right? We are oftentimes, as cardiologists, very cardiocentric, but it would be naive of us to think that there are not other effects throughout the body. And so what I really love about this framework is that we start to treat patients more holistically across a spectrum, really, of disease from prevention to heart failure and beyond. And that's what I really mean about revolutionizing heart failure. It is taking this new approach, which really is this cardio-kidney metabolic health framework, which is applicable across the lifespan of our patients. And today, we are going to be focusing on a drug that really illustrates the importance of embracing this framework for our patients with a focus on nonsteroidal mineralocorticoid receptor antagonists. So I'm very lucky to be joined by my two good friends, Dr. Andrew Sauer from Mid-America Heart Institute and Dr. Muthu Vaduganathan from Brigham and Women's Hospital. I'll be your host, so to speak. Anu Lala, I'm at Mount Sinai Fuster Heart Hospital, and I'm looking forward to a vibrant discussion this evening. So this is a little bit about our agenda. We've already done our welcomes. We are going to start with Dr. Sauer, where he's going to be talking about the role of MRAs in heart failure specifically. And then we'll move on to Dr. Vaduganathan, who's going to be sharing breaking developments and new horizons in heart failure treatments. And then what we'll do is we'll try to apply what we've learned to real-life patient cases. And then we'll take questions from the audience and from those of you who are joining us online. So without further ado, I'm going to introduce my good friend, Dr. Sauer.
Thank you. Well, thanks, everyone. Thanks, Anu. Thanks, Muthu, for being here. It's just fun to just kind of have a conversation. Again, we're friends up here, and we also encourage our audience, if you have any particular desire to interject, ask questions, we should be, we should have plenty of time to really dive into this space. And I do think we are at exciting times, and my goal for this part of the presentation is to really set the stage for what you're about to hear from Muthu. Really sort of how did we get here? Why are we starting to talk about this disease differently? Instead of just saying we're talking about heart failure or HFpEF, we're using phrases like disease-modifying therapies. We're using phrases like cardio-kidney metabolic health. And The reason we're pivoting that direction is because as we've advanced many of these therapies over the past 5 years, and let's not forget, just 5 years ago, we were talking about HFpEF as this disease that was so heterogeneous and we didn't understand it, and all we really had was loop diuretics and adjusting medicines to treat comorbid conditions. And now we have the introduction of what we're going to call a pillar therapy for HFpEF and cardiac kidney metabolic disease. So we've learned a lot about the disease by seeing how these medications work, and then that teaches us kind of in reverse more about pathophysiology. So you'll see that theme as a thread today. So again, I'm going to set the stage and then toss it back over to Muthu to kind of take us through the most recent evidence generation that's happening that gives us all the reason for this enthusiasm. So just to remind everybody, the mineralocorticoid receptor space it's a really important space in the pathophysiology of cardiac kidney metabolic disease and heart failure in general. Remember that at the collecting duct, aldosterone is involved with resequestration of sodium and also potassium exchange. And so ultimately, we do know that it's important for how our patients participate in natriuresis. We also know that the mineralocorticoid receptor is highly implicated in downstream markers of fibrosis and inflammation. And that's at the heart and the kidney level in particular. And so we need to keep that in mind, that it really is a therapeutic opportunity for intervention at the aldosterone level to help with heart and kidney protection. And so when we think about targeting aldosterone, again, this is nothing new. We've been seeing this in heart failure for more than 2 decades. We know that it has implications in heart failure with reduced ejection fraction, showing clear evidence that there's reverse remodeling, and that's seen in imaging such as echocardiography, reverse remodeling, reduced ventricular size and volume, improved ejection fraction. We see electrical remodeling, being able to narrow the QRS. We see markers of reductions in fibrosis and hypertrophy and antiarrhythmic properties. And then at the kidney level, we see evidence that there is an opportunity to reverse albuminuria. And now we have cardiologists routinely checking UACRs, which we never used to do before because we realized that we can modify that and that it has implications for the kidney and intrinsic kidney disease and inflammation. We also know that it can mitigate the risk of hypokalemia, which is a very sincere, legitimate threat to our patients. We know that sudden death, for example, in rails was one of the mechanisms of death that was probably mitigated by avoiding as much hypokalemia, as well as alkalosis and diuretic resistance. TOPCAT is a really important study to have in our frame of view and thinking about history here, because TOPCAT was our opportunity to apply spironolactone, which I always say had enormous power in HFrEF. Remember, the number needed to treat to prevent death in rails was less than 10. One of the most powerful therapies we have, one of the reasons why I care so much about talking about it, one of the reasons why I'm so loud about using it as part of our 4 pillars for HFrEF. But when we applied spironolactone to patients with ejection fraction of 45% or higher, as what was done in TOPCAT, patients were randomized to receive spironolactone versus placebo. And unfortunately, we did not see the primary endpoint met, which was a composite of CV death, aborted cardiac arrest, or hospitalization for heart failure. In addition, there were some significant important differences in serious adverse events, most notably hyperkalemia. We're talking about basically a doubling rate of hyperkalemia in this population. And it was actually worse for the patients that had the most notable clinical effects. So the guidelines have given a very lackluster recommendation for spironolactone in this patient population because of TOPCAT. And we have to keep that in mind. We are talking about a 2B recommendation for mildly reduced ejection fraction and a non-existent recommendation essentially for HFpEF in the European guidelines, as well as a 2B recommendation in the US guidelines. There are some important irregularities to keep in mind with TOPCAT. For one, in Russia, Georgia, we saw that the patient population was just different. They had different event rates. It looked almost like they didn't have heart failure, and that's a concern. So we're not entirely sure who these patients were, but they don't really look like the patients that we're talking about with HFpEF. Also, spironolactone has metabolites, specifically canrenone, that were when looking back, they were measured, and about 30% of patients in Russia, Georgia had no metabolites, meaning they didn't get the study drug. And so that's a concern. That being said, in the North America cohort, we like to think about this as potentially a positive intervention, but it's really not consistent with how we appraise evidence to go that distance. So I think we should caution ourselves before we start suggesting that TopCat, by looking at North America's, is somehow a positive trial. And so again, just to reinforce, a very lackluster recommendation in our guidelines for spironolactone in this space. So the other thing to keep in mind is that the hyperkalemia risk is not just perceived, but it's actually quite real. We recently published the results from the CARE-HK and heart failure registry, which included a number of sites in Europe as well as the United States, a number of patients in this prospective registry, and we were looking at patients who are at increased risk for hyperkalemia and the application of RASI. And these patients were followed prospectively, and what we observed is that regardless of what ejection fraction, there were challenges with optimizing RASI. It was actually a worse problem in the United States than Europe, so kudos to Europe, they're doing a better job. Unfortunately, we got to get our act together in the United States. That being said, 1 out of every 3 patients had a clinician-defined, investigator-defined hyperkalemic event. Of course, in this higher risk population, but that's the patients we're really talking about when we think about patients with cardio-kidney metabolic disease who have some decline in their GFR, some elevation in UACR, intrinsic kidney disease, and heart failure. So this brings us to sort of the hypotheses we have before us, which is to expand into this new arm of nonsteroidal MRAs. I'll make this real easy for you. Esaxerenone does not even exist, so we don't need to talk about it. Finerenone and balsartanone are the only ones that are available in a sense, either through commercial availability or through clinical trial. And there are some distinct differences besides the fact that their structures don't include a steroid moiety. Notably for finerenone, it's a short half-life and it has very balanced tissue distribution across the heart and the kidney. Also probably has an improved profile for reducing UACR compared to spironolactone and eplerenone, and obviously has no sexual or corticosteroid side effects. So again, it's a bulky molecule, non-steroidal, high potency, high selectivity to the mineralocorticoid receptor, no CNS penetration, no sexual side effects, short half-life, very balanced distribution across heart and kidney. So that's a really important take-home point. There's an idea out there that finerenone has never been put head-to-head with traditional MRA. And that's actually not true. That doesn't mean it's been in phase 3 clinical trials, but we had some important early evidence that you could compare these two head-on. And obviously, one of the things that we want to know is, does nonsteroidal MRA finerenone have the same potency as it relates to the things we care about by reducing fibrosis? And indeed, compared to a much higher dose of eplerenone, it certainly does. And this is really important to think about why it should be more effective. And again, this 10 milligram dose is considered a kind of starting dose in the clinical studies. The other program I like to point out is ARTS. You know, in early phase 2A, this is 390 patients with heart failure and CKD randomized to receive spironolactone, up-titrated to a dose of 50 milligrams versus a maximum dose of 10 milligrams of finerenone. And what you see here, and I know it's a little bit hard, you have to squint your eyes a little bit, but I'll just tell you what we're seeing here is that the markers we care about, so the efficacy markers here being NT-proBNP and reduction in UACR, were just as potent when you look at this higher dose of spironolactone, 50 milligrams, because we know most patients don't even get to that dose. Most patients end up somewhere around 25 milligrams, and compared to, again, this starting dose of 10 milligrams of finerenone. But meanwhile, look at that top right corner. You see a very significant difference in adverse events, most notably renal failure, GFR decline, renal impairment, and a significant difference in hyperkalemia. So for us to posit that nonsteroidal MRA finerenone is potentially safer from a hyperkalemia standpoint compared to spironolactone, and for folks to say, well, there's no head-to-head evidence, I would say, you just got to look a little deeper. I think we have some safety evidence to back that statement. As we move forward into, Muthu is going to be presenting the heart failure science. just to kind of finish setting the stage here, Figaro DKD was a follow-on of Fidelio DKD, and these studies looked at the hypothesis of patients with declining GFR as well as elevated UACR, so markers of intrinsic kidney disease, in the patients with diabetes, and were able to show that when randomizing patients to finerenone versus placebo, there was a 13% reduction in CV death, non-fatal MI stroke, heart failure hospitalization in patients with type 2 diabetes and chronic kidney disease. So this further bolstered the hypothesis that this could, in fact, be not just a cardio-kidney metabolic therapy, but a heart failure therapy. And ultimately, we did see, compared to placebo, some difference in hyperkalemia, as well as some changes to GFR, but discontinuation of drug due to hyperkalemia was really, really low. So generally very safe. So last year, literally on the same day as Fine Arts was presented, we presented a paper that I was just referencing here for you, so that you can see again how we got to this point to a year ago when Fine Arts was presented with great fanfare for understandable reasons. But in summary, MRAs for heart failure are underused due to safety concerns, including hyperkalemia, which is real for our patients, particularly with cardio-kidney metabolic disease. Also very real sexual side effects concerns for the men that I see in clinic. I tell them that if they on spironolactone, there's somewhere up around a 10% likelihood that they'll have tenderness around their nipples, and this is a real problem. And it doesn't go away quickly. It's a really frustrating problem. So I really avoid spironolactone for most of my male patients. Current evidence supports the use of steroidal MRAs for HFrEF, but it's inconclusive about mildly reduced ejection fraction and HFpEF. Nonsteroidal MRAs show great promise due to superior specificity, potency, and tolerability, and safety likelihood. And the future trials that we're going to talk about are really there to evaluate both steroidal, but most notably for tonight purposes, nonsteroidal MRAs for reducing heart failure and cardiovascular events. So with that, I'm going to hand it over to my friend Muthu. Thank you.
So Muthu, before you get started, we've got a couple of questions from the audience, if that's okay.
Yeah.
And I lost them somehow. Hold on, let's see if we can get this. Here we go. Okay. Would you say that there's any role for finerenone in the treatment for HFrEF, based on the fact that you talked about HFpEF?
It's an important question. Again, I'd refer you to that paper I just pulled up that gives you the landscape of what's coming. This is actually being evaluated as part of what we're calling the Moonraker program. In one of the programs that's coming and actively enrolling, called the Finality HF study, we are exploring the hypothesis that for patients who are either intolerant of steroidal MRA or ineligible for ineligible for MRA, steroidal MRA, those patients can be randomized to finerenone versus placebo in HFrEF. They obviously have to have heart failure and have enough symptoms and have elevated natriuretic peptides, but the inclusion criteria are relatively broad. And I think that what's also nice about the rest of the Moonraker program is it's highly pragmatic clinical trials. So if you're a site that is aware of this, again, we can talk later, but would really love to help encourage enrollment, because that's how we're going to understand that question, is we need to put it to the test.
Yeah.
And while those data are accruing even today, because the initial indication for finerenone was in diabetic kidney disease, if people have that intersection of HFrEF, diabetes, and kidney disease, finerenone can still be used in that population and can be used safely.
Yeah, and I'm certainly doing that with my patients as well. I think reminding us that though diabetes and chronic kidney disease are risk factors for heart failure, once you have the diagnosis of heart failure, they are also comorbid conditions. And so the indications are not just lost when patients have that diagnosis of heart failure. Andrew, you're the perfect person for this question. What serum potassium level would you not feel comfortable with when you're initiating an MRA?
Well, the way we can look at that is how are we conducting the clinical trials right now. And so basically, if the potassium is not greater than 5, then you can start it. And what we try to do is, if we're talking about finerenone specifically, we err on the side, in my clinical practice, I err on the side of caution. So for patients who have a GFR less than 60, who have a potassium close to 5, I will just start 10 milligrams and then recheck labs and just kind of monitor that closely. But for patients who are receiving it for heart failure, the target dose is actually 40 milligrams. But you have to have preserved GFR, normal potassium. So a lot of patients won't get to that dose.
And a public service announcement related to that question, patients at a potassium level of 5.0 are at much lower risk than a patient with a potassium level of 3.8, 3.5.
Yes.
And so while we consider hyperkalemia to be one of the most significant electrolyte abnormalities, hypokalemia is actually a devastating consequence to the myocardium and can increase arrhythmogenicity, can actually activate and upregulate the renin-angiotensin system because it's a direct input to aldosterone release is hypokalemia. So avoiding hypokalemia, especially diuretic-induced hypokalemia, might even be one of the factors that why MRAs actually work.
Well, I hope you dig into this a little bit more with your presentation, Muthu, because if you take 2 patients, or you take 100 patients, and half of them have a potassium of 5, but they're on finerenone, versus the other half have a potassium of 5 and they're on placebo, the patients on finerenone actually do better. And that's an evidence-based statement. So despite the concern for hyperkalemia, you're better off being on finerenone, even with that potassium.
I think that's such a critical point. You made that earlier with spironolactone as well. I think this is a nice practical question. At my center, I noticed some providers stopping MRAs due to a concern that it contributes to excessive hypotension. How do you counter that? And what would you say is the blood pressure profile for non-steroidal MRAs?
I think that's a perfect plug for some of the data that you're going to see. But what we do know is that the hypotension related to MRA is modest and can be mitigated by addressing volume status and addressing the hemodynamics. I mean, that's the short version, but you're going to see more from Muthu on that.
Yeah. Finerenone, like all MRAs, do lower blood pressure. MRAs, steroidal MRAs, for instance, are a cornerstone of management of resistant hypertension and are commonly used in those patients. Finerenone has a modest blood pressure lowering. In the heart failure studies, it's about a 3 millimeter mercury average blood pressure reduction. Of course, some might garner greater reductions, especially if their starting blood pressures are higher. And finerenone may have a role as well in resistant hypertension patients with coexisting kidney disease and heart failure.
And remember, we've learned this with other therapies too. Remember, with Paradigm, there was a distinctly different adverse event profile as it relates to orthostatic hypotension for sacubitril valsartan versus enalapril. Yet when we did Pioneer, patients came in congested. We learned that adverse event differentiation went away because those patients were less likely to be volume deplete. They were volume excess by definition. They were admitted with congestion. In other words, the take-home kind of teaching point for your patients is if you want to avoid hypotension related to decongestive heart failure therapies like MRA, like ARNI, make sure you're paying close attention to their markers of congestion or preload insufficiency. So do your orthostatics, do your best to try to tease that out, because address the volume status first before you pull off the drug.
Yeah, important points. Muthu, can you talk to us about whether finerenone's effects are dose dependent?
Really, really important question. So all MRAs to date have been tested in target dosing schemes. So these aren't fixed dosing in which one dose versus placebo in all of the pivotal trials. That goes for the steroidal MRAs and the non-steroidal MRAs. So all patients are started on starting doses, and then up titration to target dosing was achieved in the vast majority of patients. About 75% of patients reached target dosing, including in those with preserved kidney function, a GFR above 60 at 40 milligrams, and a GFR below 60 of 20 milligrams. So the dosing scheme seen in the Fine Arts heart failure trial is what should be applied when we treat our own patients. Same is true for the steroidal MRAs. Steroidal MRAs are started often at low doses and kept at that doses, but clinical trials targeted higher doses than is commonly used in clinical practice.
Yeah, perfectly stated. And then the last one for this segment, I love the questions are just rolling in. Andrew, can you comment on the fact you talked to us about exercising caution when interpreting geographic differences in TopCat? This is a specific question, is it fair to dismiss TopCat USA while embracing maybe a phase 2 study as evidence of superiority of finerenone over spironolactone?
That's a fair question. Thank you for that. I think, I am not looking to be accused of dismissing TopCat. I have been a champion of MRAs in general, and it's what we had when we had it. But we need to be honest about the fact that when we appraise phase 3 clinical trial evidence, TopCat didn't hit the bar, period. And then when you want to juxtapose that to the phase 2 data I referenced, I wasn't trying to make any claims about clinical efficacy. It's a phase 2 study. So I think it's really more of a point that I'm trying to dispel some of the myths out there that there's no safety data that we can refer to involving head-to-head nonsteroidal MRA versus steroidal. I know Muthu's had to deal with this too. There are people going out there saying, we've never seen head-to-head, we don't really know. Well, that's not really true, and that's the reason why I reference it. And phase 2 studies, 2A studies by design, are safety studies. That's the primary purpose. So I think it's still fair to at least put that in the menu of topics for evidence generation.
Yeah, thank you for that clarification. So Muthu, tell us what's on the horizon. What's next in this exciting field?
Fantastic. Thank you, Anu. And my main disclosures are that I was involved in the fine arts heart failure trial. And my second disclosure is I'm a common user of spironolactone. And so I had fun with the session. I hope it's fun and engaging for you as well. I attempted to juxtapose the available data that we have from TopCat, because as many in this room, we may believe that there are kernels of truth in TopCat that should be pursued, and with the data that was recently released from the fine arts heart failure trial with finerenone. MRAs have taken a remarkable journey in heart failure, kidney disease, and now this broader construct of cardio-kidney metabolism. MRAs are one of the most commonly used therapies in the heart failure armamentarium over time. In fact, we've had over 50 years of clinical history using these therapies. However, in the recent years, we've seen accelerated development, particularly related to many of the safety concerns and poor adoption of steroidal MRAs, such as spironolactone and eplerenone. And several therapies have recently been developed, so-called nonsteroidal MRAs or next-generation MRAs, with differentiated profiles, particularly either a broader efficacy profile or better safety, and I'll take you through that evidence. And while traditional MRAs have been very well studied in select populations, like heart failure with reduced ejection fraction, you will see the newer generation MRAs have a much, much broader portfolio. In fact, for instance, finerenone has been studied in over 20,000 randomized participants across these trials. So fine arts heart failure was a randomized clinical trial testing finerenone, the nonsteroidal MRA, in heart failure with mildly reduced or preserved ejection fraction. These were all symptomatic individuals, and we wanted to ensure they truly had the heart failure syndrome. So they had evidence of elevated natriuretic peptide levels, they had evidence of structural heart disease, and many had recent diuretic use within the last 30 days. These patients were enrolled across clinical care settings, whether in the hospital, recently hospitalized, recently discharged, or in ambulatory care in the office-based setting. In fact, fine arts was specifically designed to enrich patients in that peri-discharge period, either actively hospitalized or recently discharged, and is probably one of the most well-represented trials of that subacute population or acute population of heart failure. The exclusions were potassium levels of 5.0 and a GF or above, or a GFR less than 25. Finerenone, as I mentioned, was a target dose scheme, so patients were started either on 10 or 20 milligrams and then ultimately titrated to a target dose of 20 or 40 milligrams, depending on their baseline GFR, and they were compared against matching placebo. This is one of the largest HFpEF trials conducted to date with 6,001 randomized participants. The primary endpoint was a composite of cardiovascular death and total heart failure events. So you can see that in 2025, patients randomized to placebo are experiencing a very, very high rate of clinical events. And so HFpEF, while many may consider it an indolent disease that we see in the outpatient setting, here you can see many patients are being hospitalized, are experiencing worsening congestion, and are dying from cardiovascular disease. And finerenone led to a 16% reduction in the primary composite outcome. Because of these high event rates experienced by these patients, the absolute rate reduction was about 3 per 100 patient years. So now I'm going to start to juxtapose this evidence. So what are some of the key differentiating factors, at least from my perspective, that we see between the newer finerenone data with fine arts heart failure and what we had learned from TOPCAT? So TOPCAT on the right side, you see that this is the effectiveness of the drug across the ejection fraction spectrum. And much like other renin-angiotensin system inhibitors, we saw that there was attenuation of benefit in patients with very high ejection fractions. Many posited that was because of downregulation of the RAS system in those individuals, and you can see that there's attenuation over time. In fine arts heart failure, we saw no such attenuation. In fact, even patients with an ejection fraction above 60% still did benefit, and perhaps this might be because of the broader effects across this cardio-kidney metabolic spectrum that I'll touch on. The second key issue is that fine arts heart failure was particularly enriched for that subacute population of hospitalized or recently hospitalized individuals. And here you can see that those individuals, about 20%, 1,200 people, so not a small subgroup here, who were randomized just within 7 days of discharge or in the hospital, had at least numerically, even a greater benefit, and certainly from an absolute standpoint, benefited the greatest in this population. So you can safely start these therapies, not just in the hospital, not just in the peri-discharge period, but also in ambulatory care. In TOPCAT, which wasn't specifically designed for this high-risk hospitalized cohort population, you don't see such an enriched benefit in the peri-discharge period. Here you're seeing relative consistency in the ambulatory care setting. This is time from previous heart failure hospitalization. As you move away, you're seeing a fairly consistent effect, but in this peri-discharge period, you're not seeing that outsized benefit. The third key differentiator is the metabolic effects. So of course, these are chemically distinct compounds, so they might have off-target metabolic consequences that might be distinct. In fine arts heart failure, we saw a reduction in new onset diabetes. Many of you might be wondering, how could that be? This is a MRA without direct glucose lowering properties. In fact, there was no direct overall hemoglobin A1C reduction. However, these drugs do affect metabolism. They improve patient functioning, patient movement, and that over time might directly lead to reductions in new onset diabetes. The MR receptor, of course, is a systemic receptor, including on many of the endocrine organs, and so perhaps there was also a direct effect in reducing new onset diabetes. Spironolactone has a much broader profile in terms of its targets and has off-target metabolic consequences. These are early phase trials, but many had shown, these are small early phase trials, but many showed, in fact, an adverse consequence on metabolism with increases in glycemia. And some of our own patients, we sometimes see this in which they have small changes in glucose or hemoglobin A1C. The fourth key differentiator is on the arrhythmia axis. And so recently we presented these data from the Fine Heart program. This was the broader program of all finerenone phase 3 trials of fine arts heart failure together with the previous diabetic kidney disease trials. And here you can see a meaningful 17% reduction in new onset atrial fibrillation. We knew the MR receptor is richly expressed in the atrium, so perhaps blocking the MR with a potent antagonist like finerenone might improve atrial remodeling, atrial fibrosis, and reduce atrial arrhythmogenicity. In TopCat, with the limitations that atrial fibrillation was not adjudicated, different from what was seen in fine arts, we don't see a direct benefit here in atrial fibrillation, new onset atrial fibrillation in the TopCat trial. The fifth, and to me the most important differentiator, is that there is a broader efficacy profile with finerenone. Finerenone, as was mentioned, initial label was in diabetic kidney disease. It's approved and is widely available in many countries around the world for type 2 diabetes and chronic kidney disease based on 2 large-scale positive pivotal randomized clinical trials. This now joins together with the more recent heart failure data from the fine arts heart failure trial, and this is the pooled experience. So this is taking a look at the sort of 1,000-foot view here and saying across the 18,000 patients randomized across these 3 randomized clinical trials, we see improvements not just in cardiovascular endpoints, not just in kidney endpoints, but also take a look at the bottom. All-cause mortality is reduced by 9%. All-cause hospitalization, preventing hospitalization regardless of cause, not just heart failure related, but any cause, is reduced by 5%. And that composite of morbidity and mortality of all-cause death or hospitalizations reduced. So this is a systemically acting drug on a systemic receptor, and here you're seeing systemic biological effects across cardiovascular, kidney, and mortality outcomes. Spironolactone has been less studied in kidney disease populations. This was one recent trial called the BARAC-D trial, in which low-dose spironolactone in relatively unselected patients with stage 3 CKD was tested in about 1,300 patients. The primary outcome was actually a cardiovascular outcome. You see no difference compared with usual care. These are, of course, much different in terms of their trial designs. The finerenone trials in diabetic kidney disease were placebo-controlled, large-scale trials, an order of magnitude larger. The pooled experience of the DKD trials were 13,000 patients. Here you're seeing only 1,300 patients. So there are certainly differences in these designs, but that said, the weight of the evidence certainly now favors finerenone because it's much better studied in that diabetic kidney disease population. Now, what about safety? So until now, I've talked about 5 key differentiators, at least in my view, on efficacy, that finerenone, nonsteroidal MRAs appear to have a broader efficacy profile. But what about safety? Because of course, this is where we started and where I think many clinicians ultimately still will make decisions at the margins around safer drug options. We want to provide our patients not only effective therapies, but also safe therapies. So there have been two head-to-head randomized clinical trials. These are small trials, but they were designed for safety assessments. And here you see on the left side, I presented a more recent trial called the COMPASS trial, presented last year. This is an open-label trial of primary aldosteronism. So this is finerenone at usual doses compared with spironolactone. And you can see that head-to-head, finerenone resulted in lower increases in serum potassium levels, about 0.2 compared with 0.5. On the right side, you had already seen data that Andrew had presented about the ARCH trial. This is again a larger trial now, 389 patients with heart failure and kidney disease, common intersection, common patients that we treat in our own clinical practices. Here you can see marked differences in adverse events related to kidney failure, renal impairment, and hyperkalemia. And this is almost identically borne out if we take indirect looks at fine arts heart failure compared with TopCat Americas. So we said that from the COMPASS trial, you saw a 0.2 increase in serum potassium. You're exactly seeing that increase in the fine arts heart failure trial. You see that potassium increases very early, within weeks of initiation, and is sustained throughout follow-up. 0.2 milliequivalent per liter was exactly the increase seen in Fidelio DKD, and exactly the increase seen in Figaro DKD. So we have great certainty that there are modest increases in serum potassium on the order of this 0.2 range. In TopCat Americas, there was an increase by 0.3, so not a major mean difference in increases in serum potassium. But this actually translated to meaningful threshold changes in hyperkalemia. So 0.2 versus 0.3 translated to about twofold increases in hyperkalemia of potassium above 5.5 in fine arts heart failure, and about a threefold increase compared with placebo in TopCat Americas when we look at that group of patients that appeared to benefit in TopCat Americas. A 0.3 milliequivalent mean difference resulted in 3 times excess of patients crossing over that threshold of 5.5, where we may feel some uncertainty about whether to continue the therapy. These drugs don't alter overall kidney profiles. Here is a noteworthy related to all MRAs. You see this early reduction in GFR. This should not be mistaken as acute kidney injury. In fact, if you examine patients' urine, there are no markers of tubular injury in this early phase. This is an entirely hemodynamically mediated reduction in GFR that occurs early, within days to weeks of initiation of the therapies, and stabilizes over time. When we stop the therapy, it's entirely reversible, suggesting that it's entirely a phenomenon of target engagement on the kidney rather than any acute kidney injury. Here you're seeing the data with finerenone. You're seeing this expected early eGFR dip. The exact same is seen with the steroidal MRAs. Here you're seeing data from TopCat Americas on the right side. So that early GFR reduction shouldn't be a reason for concern and shouldn't be a reason for treatment discontinuation. I do want to touch on sex-related side effects. While this might be considered a minor side effect of spironolactone, many of us who use this therapy a lot in clinical practice, especially among men, we do see that gynecomastia is real and does cause treatment discontinuation. Many individuals, here you're seeing very low rates of sexual side effects, and there's no difference between placebo and finerenone in the fine arts heart failure trial. In TopCat Americas, you're seeing actually an excess rate of drug discontinuation related to sexual adverse events. And so this is meaningful, not just seen in clinical trials, but I think all of us can agree we also see this in clinical practice. And so avoiding those side effects is a reasonable one. So we saw those guidelines from prior to the fine arts heart failure trial. And while many of us did believe that spironolactone in the TopCat trial did have potential efficacy, there were kernels of truth there that should be pursued, this didn't meet the bar for guidelines. And you saw the ESC didn't afford any guideline recommendation, not even a class 2 recommendation for use in HFpEF. The FDA considered spironolactone based on the TopCat trial, but ultimately did not approve it. So spironolactone doesn't have an approved indication for HFpEF. And so at this point, we just had lukewarm evidence to inform guidelines. Now we're starting to see, after the fine arts heart failure trial, we're seeing global guidelines being updated. We're waiting the large guidelines from the US and Europe, but here are the Japanese heart failure guidelines that have now positioned under SGLT2 inhibitors, which have multiple randomized clinical trials in this target population of HFpEF, as a class 1 recommendation. We see now finerenone has entered a class 2A, strongly considered in eligible individuals as a 2A recommendation, and that is above other MRAs like spironolactone and eplerenone as a 2B recommendation. Andrew did mention other therapies that are in the pipeline, and this is such an exciting time, and I'm so glad that there is renewed interest in this pathway. We've long understood this pathway is important for cardio-kidney disease. Now we are trying to target this pathway more effectively and more safely. And so we heard a lot about finerenone in the fine arts heart failure trial. There are several other trials that are underway targeting this exact axis including MR modulators like balcinrenone, which might have differential effect at low or high circulating levels of aldosterone. This is being studied in the BALANCE-D heart failure trial. And there's great interest in inhibiting this pathway even upstream. Might we not just block the aldosterone receptor, but can we actually reduce the very levels of circulating aldosterone with aldosterone synthase inhibitors? And so these two are being studied in heart failure in the EASY heart failure trials. This is such a rich time in re-examining and re-energizing the field of heart failure, not just in terms of treatment, but also prevention of heart failure with targeting this mineralocorticoid aldosterone axis. And these are some of the completed and ongoing trials that are, and you can see the ones that are bolded are the ones actively enrolling. And I would say that this is probably one of the most exciting and active areas of clinical research across all of heart failure today. So watch this space, a lot of new therapies that will be studied, including re-examining spironolactone's role in HFpEF. There are two ongoing trials, SPIRIT-HF and SPIRIT-HFpEF, that we hope to soon see results from, which are following TopCat to say, might we have second shots on goal here and re-examine spironolactone in HFpEF? So today we have many drug therapy options in the HFpEF syndrome, including the SGLT2 inhibitors, which have the strongest body of evidence. There are the class 1 recommended therapies, including in those recent Japanese guidelines. And about 13% of individuals, about 800 people, were treated with an SGLT2 inhibitor at the beginning of the Fine Arts heart failure trial. But of course, evidence quickly evolved during Fine Arts, such that by the end of the trial, almost 30% of people were treated with an SGLT2 inhibitor. Reassuringly, the benefits of finerenone were entirely complementary, or entirely additive. Here you see consistent benefits irrespective of if people were treated or not with an SGLT2 inhibitor at baseline. We also have more direct evidence. These data were just published in the New England Journal of Medicine earlier this year, called the Confidence Trial, directly testing, does 1 + 1 = 2? Can you use finerenone and an SGLT2 inhibitor together safely, but also effectively? And here you see UACR lowering. This is a diabetic kidney disease population. You say UACR lowering was similar with finerenone and an SGLT2 inhibitor and was mathematically identically additive when you use the combination together. So these drugs not only provide complementary benefits, but the trial also showed that it could be safely combined. So these therapies now form our standard of care as a part of management of HFpEF in 2025. So I look forward, the strongest body of evidence today for treating HFpEF are the SGLT2 inhibitors and the MRAs. And we hope we've shared some of the evidence that the nonsteroidal MRAs have a stronger efficacy profile at the present time. And steroidal MRAs are certainly ongoing, are still being studied today in ongoing trials, and we'll see how that shakes out. In select individuals, of course, who remain congested despite that backbone therapy, diuretics remain mainstay in those patients. We're increasingly seeing that obese individuals or patients with overweight or obesity may be candidates for incretin-based therapies, and selectively, ARNI might be important, sacubitril valsartan, based on the Paragon heart failure trial. So it's such an exciting time of HFpEF in 2025, but soon, much like the pillared approach that we've seen in HFrEF, in my view, we're moving towards a pillared-based approach of HFpEF. And in 2025, I think we can say we have pillars of care. SGLT2 inhibitors and nonsteroidal MRAs should form our pillars of initial management of HFpEF. Thank you.
That was beautiful. Thank you, Muthu. Lots and lots of questions that have come in. I'm going to go one by one. Do you think there is a future where we can see a single pill option that would include SGLT2 inhibition and MRA antagonists?
Absolutely. I think the future is going to be around combination therapies. There are many, many compounds that on that slide, there was many compounds that are investigating specific combinations. And soon we'll see more and more trial evidence directly combining these therapies as polypills. Even at the American Heart Association, you're going to see initial data from a heart failure trial, a HFrEF trial of a polypill, combining these therapies in a single pill in an NIH-funded trial. So this is an exciting time. This is certainly going to be the future. And my view is that much like hypertension, much like diabetes, heart failure is a chronic disease in which we're trying to maintain long-term use of these therapies with high degrees of adherence, and polypills are our future.
Yeah, absolutely. I think one of the questions that came in was a reminder as to the doses of finerenone. You saw earlier that it was GFR dependent. The starting dose, if the eGFR is less than 60, of 10, up titrated up to 20, and if the GFR is over 60, starting at 20 and up titrating to 40 milligrams. Andrew, maybe you could take this one. When we initiate finerenone, we expect that initial decline in eGFR. What is the cutoff point that you think of where you say, I should stop this finerenone now? The eGFR has declined by X. And then we'd hear from Muthu as well.
Yeah, my own clinical approach to that is, again, I tend to err on the side of try to push through and make sure that I've assessed the volume status, make sure that I've addressed the hemodynamic contributors, because we know that dip, we see this in SGLT2 inhibitors as well, that dip it should be anticipated, and we should even prepare our patients for some degree of that. And I think just a kind of, instead of correcting course, just to sort of follow that through. That said, if it's a 25% or greater drop, I may say, okay, let's try to withdraw for a second, recheck, and then let's try to maybe initiate one more time. But I don't know, yeah, Muthu, what do you do in practice?
Yeah, so it's very, very important here that this dip is not only reversible, but is not associated with acute kidney injury. And I think we should be very, very specific in our language, including in our clinical notes, to avoid using terminology like acute kidney injury, because often MRAs are affiliated with AKI, and we're really not seeing that in the clinical trials. These aren't causing tubular damage. These are reversible glomerular changes with initiation and disruption of the therapy. Now, in addition to addressing reversible causes, I would say volume and blood pressure are 1, 2, and 3, and so adjusting diuretics often can allow drug continuation. The clinical trials monitored levels of greater than 30%. So if you have a GFR reduction of 30% or greater from baseline, at that point, you might take a clinical action to say, maybe I need to reassess things, pause, adjust other medications, et cetera. However, in practice, we're seeing very few instances of the large-scale reductions simply related to the drug. And if you are seeing large and profound reductions in GFR, maybe there are other causes there that are causing true acute kidney injury. And the final aspect is that this is also dependent on the baseline GFR. And so the patients we may be most worried about are those with very low starting GFRs, let's say a GFR of 30. But in fact, we see very little fluctuation in that acute GFR dip in that population. The GFR dip is actually greater when you start out with more nephrons. Once patients have more advanced kidney disease, their number of functioning nephrons go down, and so the effectiveness of that hemodynamic changes are affecting fewer nephrons. And so there's almost very minimal or no dip experienced in a person starting with a GFR of 30. If you start at a GFR of 90, you might expect that larger dip, but that's again expected and reassuring because you're still in a very safe range from electrolyte handling, volume handling perspective.
A couple other clinical pearls related to that. This is why we have to talk about the kidneys beyond just GFR anymore.
Right.
This is why I mentioned at the beginning, I'm a cardiologist that's routinely measuring UACR for my patients with cardiokidney metabolic disease, especially those with diabetes and chronic kidney disease, because to really assess the kidneys, you need to follow the KDIGO guidelines for a reason, because they are giving you a bigger, more precise story about how that patient is doing from a kidney standpoint, and also give you opportunities to advance therapies. The other thing just to keep in mind about loop diuretics, as you've seen again in the last 5 years, the revolution of new decongestive disease-modifying therapies, we're seeing that part of success, at least in heart failure, is the withdrawal of loop diuretics as those are being replaced with SGLT2 inhibitors. We also saw the same signal with STEP, HFpEF, with GLP-1s. Patients who respond favorably to GLP-1 agonists also notably come down on their loop diuretic needs. And that, again, is not, that's not a bad thing. That's a really good thing. It's a marker of improved prognosis, and it means that your therapies are working and that your patient is responding to them. So that's another clinical pearl to keep in mind. You should be anticipating that as you see that GFR go down, you might need to back off the loop diuretics to help bolster the hemodynamic support that that patient needs.
Yeah, well said. So this is a kind of fun one. If you had a patient with HFrEF and diabetic kidney disease, would you start them on finerenone, switch them out from spironolactone or eplerenone?
I do it already, yeah. I mean, I think it's mostly because I don't have to fight the challenges with prior authorization the same way. These days, at least until the FDA label for mildly reduced and preserved ejection fraction heart failure, until that label really takes hold with payers and I don't have to fight with them, if the patient has diabetic chronic kidney disease and elevated UACR, you typically need to have that documented, to be fair. They will much more readily approve that therapy. So if they happen to have HFrEF, diabetic chronic kidney disease with elevated UACR, I'm going with finerenone.
I will just add, because we sometimes do get this question of patients with HFrEF alone, not with diabetic kidney disease, who are on spironolactone, do we switch them to finerenone? And I think our guidance is no, keep those patients on spironolactone, even if
don't forget the power of rails. I mean, we've got some really compelling evidence, so I wouldn't be trying to push to switch back to nonsteroidal for those patients.
Exactly. And until additional data are available, with finerenone we'll see, with the finality trial, there's the Balance-D heart failure trial that's evaluating balcinrenone, including in that HFrEF population, and we're seeing the EASY heart failure trials, including in HFrEF. So we're going to see if we can offer alternatives to steroidal MRAs, but my view is steroidal MRAs will still be backbone therapy in that population because of really overwhelming data from those initial trials.
Yeah, do you know of any side effects on magnesium with finerenone? Has that ever come up before? That's a question that came up from the virtual audience.
Interesting. I must say,
unknown space for me.
Yeah,
So.
I didn't know either.
I've heard a lot of questions over time about finerenone. I have not heard this one, and I've got to say I don't know.
Okay, good. What do we need to make of the subgroup with recent heart failure events greater than 3 months appearing to have an attenuation of benefits?
Really, really important. So I focused on the group of patients who were recently discharged, that subacute worsening population. And that was to mainly emphasize that this is a therapy that can be implemented broadly in different clinical care settings. But of course, most or many of our patients we're seeing are in our office settings or our clinics. And in that subgroup of patients, we saw relatively the same benefits, but because those are lower risk patients, the absolute benefits that they may garner from a therapy like finerenone, and for that matter, any therapy, is going to be lower than that high risk population who are recently discharged. So my view is that you're still benefiting patients if you start them in the outpatient setting. If you start it in the inpatient setting, they really are our highest risk patients that we're meeting in the hospital, and you can have an outsized impact in terms of absolute gains.
Yeah, this is a good question and a real important one, which is, do you check UACR prior to starting MRAs and SGLT2 inhibitors? I would just make a plug, and you'll see this in our cases that we're going to be discussing shortly. We have very much come to appreciate the importance of assessing UACR routinely in our patients because we know that it has prognostic significance in our patients with heart failure. So this is very much our lane. With respect to starting it or checking it before starting an MRA or a SGLT2 inhibitor. That's part of my routine practice, and then I will survey its impact on UACR thereafter. Do you have any specific thoughts on that?
Yeah, I mean, as part of our actual protocols now, I direct our Haverty Cardiometabolic Center of Excellence, and it is standard for all patients taken into our clinic now, referred for cardiometabolic disease, essentially. Those, particularly those with diabetic chronic kidney disease, but we basically check in everybody so that we don't forget it. And so every single new patient, as part of their intake, includes a UACR. And I make sure that we are checking it annually regardless, so that you can see that trend. And it is nice to see. I don't think you need to check it more frequently than that, unless you just really want to show the patient the impact, because it shouldn't change your therapies, right? It's not like you're going to withdraw the therapy if the UACR doesn't go down. But I do think it's nice to be able to show patients, just like I show them their NT-proBNP go down when they're on optimal guideline-directed medical therapies. It really helps provide insight into that prognostic conversation that we sometimes glaze over with our patients.
Yeah,
We're so focused on, getting through the clinic encounter, we forget that there is this prognosis discussion we should be having with our patients, kind of give them their report card.
Really, really important. And just to reemphasize, any biomarker that simply has prognostic roles, we sometimes are reticent to measure these because we can have many, many biomarkers that might influence that prognostic estimate. But here you have one that is directly linked to the therapies. And while when we start these disease-modifying therapies like SGLT2 inhibitors, like nonsteroidal MRAs, you might have a modest impact on NT-proBNP levels. You might have a modest impact on improving their quality of life. But patients might say, is the drug working? And in HFpEF, we're not showing patients longitudinal improvements in left ventricular ejection fraction. We're not showing real important cardiac remodeling. So you want markers to help follow your therapies. And in fact, outside of cardiology, the American Diabetes Association and KDIGO has been very vocal about serial monitoring of UACR, particularly for therapeutic monitoring. And you actually want to target at least a 30% lowering in baseline UACR levels with these disease-modifying therapies, and to show a patient that you are protecting the kidneys actively with these single or combination therapies is profoundly important to improve long-term use and adherence.
Yeah, I think that the patient buy-in, especially in this era of polypharmacy, before we get to those poly pills, it is so important for us to show the efficacy to our patients. Maybe we'll do two more. I think they're very relevant questions. Muthu, can you share the proportion of patients that achieved the 40 milligram dose in fine arts? And if not, specifically, what was the median dose achieved? I have to tell you, something that I'm sometimes sort of guilty of is I don't always push up to the 40. I oftentimes stick at 20. We have issues with prior authorization and approval and other things.
Yeah, very, very important question. So essentially, fine arts heart failure, you can almost think of as two strata, two populations, one with a GFR below 60 and one with a GFR above 60. The low GFR group of patients, their target doses was 20 milligrams by the end of the trial. This was titrated pretty early within the first months of initiation of the therapy, and over 70% achieved those levels, that 20 milligram dose. The same exact was true for this other spectrum of patients with higher GFR. 40 milligrams was achieved in the vast, vast majority, the 70 to 80% of patients. Now, hyperkalemia rates and potassium changes was also identical. So even at 40 milligrams in this GFR above 60 population, you're seeing a similar potassium profile, meaning it is important actually in this high GFR group of patients to target 40 milligrams because you're targeting drug levels that are engaging the targets to a comparable degree than the 20 milligram dose at low GFR. So this is something that is pervasive across heart failure, and unfortunately, we do stick to low doses. But in my view, MRAs should be targeted to target doses achieved in clinical trials. And that is true for finerenone, it is true for eplerenone, it is true for spironolactone.
Just remember, though, that the label for diabetic chronic kidney disease does not include the 40 milligram dose. So it is max of 20. So keep that distinction in mind.
You make me feel better. Thank you.
Yes.
And then last question, this is about real-world practice. How are you finding it to prescribe finerenone and then have insurance companies cover the drug?
Yeah, I think I kind of alluded to this earlier, but if you prescribe it for a label that is readily supported by the formulary for that particular payer, it tends to move through just fine. But if I try to prescribe finerenone today, some formularies may not be supporting it for heart failure, for example. They just haven't caught up yet. The FDA label just came out for heart failure with mildly reduced and preserved ejection fraction. So it takes a little time for these things to catch up. You know, the label for diabetic chronic kidney disease has been around a bit longer, and so a lot of these payers are more accustomed to that. So I check the formulary, I try to see if it's in their preferred option list, and then of course you're gonna have to deal with the prior authorization. And fortunately, we have a team of people that focus on doing that, so it makes my job a lot easier.
Yeah, I believe having that dedicated team
Yep.
to go through those really helps improve workflow. So with that, I hope you guys are all awake and not in a post-dinner coma. We're going to apply some of the knowledge we have acquired over the past hour to real-life cases. And Muthu and Andrew, I'd love for your comments in between, so let's make this interactive and engaging. Okay, so this is the patient perspective. Let's talk about the real-world impact of nonsteroidal mineralocorticoid receptor antagonists. So we talked a little bit about this changing framework with which we are seeing and treating our patients, this cardio-kidney metabolic syndrome framework. And I already shared with you how much I like this framework because it allows for us to take care of our patients more holistically, where stages range from 0 to 4, 0 being that there are no risk factors, where we are emphasizing the importance of lifestyle interventions and preserving our cardiovascular health, to clinical cardiovascular disease in stage 4, or CKM syndrome manifested by coronary disease, heart failure, peripheral arterial disease, stroke, atrial fibrillation, et cetera. And what I think is so important about this is we recognize the importance of being proactive rather than reactive. And I think finerenone nonsteroidal MRAs really help us understand this spectrum of disease. And we have to remember also that it's not just cardio-kidney, this is metabolic syndrome, whereby the liver is involved and we see systemic effects of this syndrome. Muthu has put this into context for us, and I think this was such an incredibly important paper. If we use this framework put out by the American Heart Association in 2023, 90% of adults in the United States meet criteria for stage 2 or higher CKM syndrome. Again, emphasizing the importance for us to be proactive and treat patients who are at risk for heart failure, not just those with heart failure. And I think, again, nonsteroidal MRAs are a really nice example of how important and impactful that can be. And really, I think this framework also is a call for integrated models of care. Not all of us have centers of excellence like the Brigham or like Mid-America Heart Institute, where you have multidisciplinary clinics for patients, and I think this is really what we need to advocate for and what we will hopefully be seeing more of in the future, where there are broken walls and we're not operating in silos between cardiology, nephrology, endocrinology, even for that matter, orthopedics. We're seeing a vast applicability of medications across disciplines, and I think this is a really favorable change that we are seeing in our field. Muthu has led an incredible effort that was published, a 3-part series in The Lancet that was presented at ESC, again, emphasizing the role of prevention in heart failure, not only to prevent heart failure, but then also keeping prevention in mind when patients already have that diagnosis of heart failure. Finerenone is a perfect example. You heard from Andrew and Muthu. If you have an indication, which is diabetic kidney disease, regardless of whether you have a diagnosis of heart failure or not, it is indicated. Okay, so now let's apply some of this knowledge to a patient, right? So this is a 52-year-old woman that I saw in clinic. Her BMI was 27. She had no history of cardiovascular disease or other chronic conditions. She was a non-smoker, doesn't drink alcohol, and she presented to the emergency room with progressive dyspnea for 3 months. She was reporting shortness of breath with minimal activity twice a week, but previously had no exertional symptoms. You see her blood pressure is 150/82. Her heart rate is 78 beats per minute. Sinus. She had a systolic murmur on exam. She had rales bilaterally, and her extremities showed evidence of peripheral edema, but her pulses were intact and her neurological exam was intact. So these are some of her laboratory markers. You can see her NT-proBNP was elevated over 2,000. Her creatinine was 1.8. Her high sensitivity troponin 38, her eGFR 43, and her serum potassium is 5.3. She's on no medications, as we saw, and her hemoglobin A1C is 5.8, her Lp(a) 96, and her UACR was 139. Okay, so let's take a minute to digest that, and I can go back if it's helpful. Andrew, how would you approach this patient?
Great case, by the way. This is an opportunity to really make sure we fully understand this patient's disease and diagnosis list. So she already has a diagnosis of heart failure. Just so everybody remembers, the universal definition of heart failure does not require a known ejection fraction. I didn't see that you put that there, right?
Great.
So one of the important teaching points here is that you don't diagnose heart failure based on the ejection fraction. You have signs and symptoms, markers of congestion, can be manifest either on elevated filling pressures on an echocardiogram. So I'm just trying to tell you, you might actually be looking at the wrong thing sometimes at the echo, because you're focused on the ejection fraction assessment, but you didn't check to see that the patient had a PASP elevated to be 55 in the echo they got a year ago. We see this a lot in our community cardiology clinics. So this patient has heart failure. You then need to decide what kind of heart failure they have. So they do need to get the ejection fraction assessed so that you could put them in the appropriate treatment bucket. Is this preserved, mildly reduced, or reduced ejection fraction? The other thing I would do in my clinic is aggressively look for ASCVD, because it smells like it's there. So I would offer this patient a coronary calcium score, and if it's elevated, I'm going to get real aggressive with my ASCVD therapies. Not exactly the strongest statement I can make for that, but we believe that, again, prevention is more important. I'm not going to do a stress test. Notice I didn't say that. This didn't have a patient that is clearly telling me that they have ischemia. That said, if they've got heart failure, reduced ejection fraction, I'm probably going to go looking more carefully for coronary disease. But then I don't think I'm going to waste any time. I'm going to initiate an SGLT2 inhibitor today. I'm not even going to wait for the echo. I've already got the diagnosis of heart failure. The UACR measures is there. This patient, doesn't really matter what their ejection fraction is, strong recommendation for SGLT inhibitor to start today. The other nice thing about that is we might see that potassium come down, and the next time I see them, I might be able to start adding some more therapies that we can think about on that list. And I probably just paused there.
Yeah,
but those are some of my
perfectly
initial
stated.
impressions. So.
I wish we could get this kind of laboratory profile for all our patients who come to the ED, right?
Right.
Were you going to add something?
No, just important to, we're all cardiovascular specialists, and we focus on the heart, but a part of the theme of this session is also to focus on the kidney. And you note that the eGFR and the UACR here place this patient at high risk or even very high risk for kidney disease progression. Their eGFR placed them at stage 3 kidney disease, borderline stage 4 kidney disease, and then UACR between 30 and 300. The previous so-called microalbuminuria has been retermed to now A2 albuminuria. So A1 is 0 to 30, 30 to 300 is A2, and A3 is the previous macroalbuminuria above 300 milligrams per gram. So this patient actually, based on the KDIGO heat map, starts to get in the red category of very high risk for kidney disease progression.
Yeah, and you could even argue that if you could do it safely, you'd be thinking about an ARB, honestly.
Yeah.
But lots of blood pressure, there's intrinsic kidney disease, as you just point out with KDIGO. The only thing I'm concerned about is the potassium. But aside from that, I think you'd be looking to add that soon.
Right. And what I love that you both illustrated so nicely is the fact that this woman's saying, listen, I have no comorbid conditions, I don't drink, I don't smoke, I'm not on any meds, and she's presenting in clinical heart failure. So she's going from maybe a self-knowledge of 0 to 100 just with this admission. So really important. Now, so let's talk a little bit more about her other presenting signs, symptoms, and studies. So she's in sinus rhythm, as I mentioned, but she has a left bundle branch block. You can see her chest radiograph shows curly B lines, evidence of congestion and volume overload, again, justifying or really supporting our clinical diagnosis of heart failure. And on echocardiogram, you're exactly right, Andrew. We didn't need to know her ejection fraction because she was in clinical heart failure. But she has an ejection fraction of 20%, and commensurate with her dilated left ventricular and right ventricular chambers, she also has moderate MR and TR. So, what would you start, and in what order? You already kind of cheated a little bit maybe, because you said you'd start that SGLT2 inhibitor, which I completely agree with.
Yeah, so I'm going to look to see if I can now actually, instead of talking about the ARB, I'm moving directly into sacubitril valsartan, right? Because this is a therapy that has a strong indication when you have heart failure, which we already made the diagnosis before the ejection fraction, but when you have reduced ejection fraction, you have symptoms and you've got markers of congestion, this patient's likely to benefit significantly. Again, I'd point you to Pioneer when you think about that NT-proBNP. In just 48 hours after initiation of sacubitril valsartan, you had a greater than 50% drop in NT-proBNP in Pioneer. It's a very powerful therapy on the things we target. So that's going to get on my list pretty quickly. Again, I'm just going to be watching that potassium carefully. And then, of course, my favorite drug, I'm going to be pushing on seeing if there's an opportunity to sneak on some low-dose spironolactone pretty quickly. And of course, everybody knows about the beta blockers, but always keep in mind that you want to make sure this patient's optimized. But this is a patient who's naive to therapy, has a huge likelihood of benefiting tremendously by all markers: reverse remodeling, natriuretic peptides, improved clinical events, avoiding hospitalization and death, without even going to the cath lab, which I know is on everyone's mind as well. And I would add that to the list, but it's the meds that I'm going to focus on to start. I don't know, Muthu, what do you think?
Yeah, no, just to add, that potassium is going to give us pause to initiate spironolactone up front, but of course this patient is actively congested as well, and so we're going to decongest them with diuretic therapy. That will bring down their serum potassium levels. We will start and prioritize SGLT2 inhibitors and ARNI, which both also lower serum potassium levels. And so by the end of hospitalization, by the end of that worsening heart failure episode, many patients can in fact tolerate low-dose spironolactone. And if they cannot and they have persistent evidence of hyperkalemia, this might be an individual where we would, because she's at such high risk of clinical disease progression with HFrEF, that we may consider a potassium binder, for instance, to lower the potassium levels to facilitate use. Beta blockers, of course, are going to be important maybe after the initial episodes of decongestion. Her baseline sinus heart rate is 70. She can certainly tolerate some degree of beta blockade. And then in follow-up, we will have that left bundle in our mind about whether we need to address CRT-P or D, depending on her degree of LV remodeling and improvement.
So look at all the therapies she has available to her. There's no reason why this lady needs to suffer or die from this disease. That's the other really thing. It's like we sometimes wait so long to really get aggressive with therapies, and then we wonder why the patient a year later has a lot more clinical heart failure. So get very aggressive, because all these tools are in your toolbox to help this patient. There was an actual question out there on it. Yeah.
Sure, we'll do that. We were going to wait till the end. Would that be okay? Okay. Well, I just want to make sure that we stay on time. So I'm going to share with you, after 3 months, I did exactly what you wanted me to do, Andrew. She was started on sacubitril valsartan. She's at 49.51 twice daily. She's on carvedilol 12.5 twice daily. She's on furosemide 20 milligrams twice daily. She's on dapagliflozin, and she's on spironolactone 12.5. And now her potassium's 5.8. So what do we do next? Do we increase her loop diuretic? Do we reduce the ARNI? Do we discontinue her spiro? Do we add a potassium binder? like Muthu suggested? Do we reduce her dietary potassium? Or do we consult a nephrologist?
And I should note, and I was remiss to mention that ARNI, when initiated de novo, will increase your serum potassium because of the ARB component. However, ARNI, when you're switching from a dose equivalent renin-angiotensin system inhibitor, like an ACE inhibitor and ARB, reduces your serum potassium over time. So that's one of the caveats, but that's aside from the presentation here. I think that dietary sodium is something we never talk about and is hugely, hugely important and should be a part of every one of these discussions before we ever consider any therapeutic action to address the potassium. Potassium's quite high, it's 5.8. Usually is in this range, at least for me, is the range where I will pause therapy, will pause MRA therapy, address some of the other issues, and then try to re-expose the patient to an MRA. I think based on just what you've presented in our history, I think we are moving towards a potassium binder. Very common in this population with stage 3-4 kidney disease with presence of albuminuria. Both the number 1 and 2 reasons why people develop hyperkalemia is albuminuria and low GFR, and coexistence of heart failure makes this mandatory therapy. So we need to treat this individual with an MRA. It is critical because it is disease modifying and may even preclude her from requiring, for instance, a device down the line like an ICD or even a CRT.
Yeah, I mean, I think that's the take home, right? Don't just pull back. It's the same thing when we're decongesting our patients. Don't just pull back the diuretic. Treat what is in front of you and recognize the value and importance and impact of these medications for benefit. Okay, so let's take the same patient, but let's change the scenario up a little bit. So again, 52, but now the BMI is just maybe a point higher, 28. She has no history, like we talked about, allegedly, not a smoker, no alcohol. Again, she's here with clinical heart failure, as we stated, same blood pressure. Now these are the labs, slight differences. Same creatinine, 1.8, but now the UACR is over 300, 339. The A1C is 6.8. And now the ejection fraction is known to you, it's 59%. So she clinically fits the scenario of heart failure with preserved ejection fraction, right? This is a patient with HFpEF, with CKD, and diabetes. So the indication then for nonsteroidal mineralocorticoid receptor antagonists is there, 100%, and I would add independent, as we've mentioned several times today, of her diagnosis of heart failure. So we've talked a lot about this framework. I urge us all to keep this in mind because I do think it is so important when we're treating our patients. And she fits really CKD or CKM stage 4 in this scenario. This is just a nice recognition reminder as to what the risk factors are for heart failure, especially as we're talking about prevention of heart failure. But notice how albuminuria and CKD are considered real risk factors. We used to think that that wasn't our lane. It very much is our lane. I hope that you walk away from today's session remembering that and feeling empowered to actually mitigate it and treat it. So we all know this, and I'm just going to remind us of the fact that the heart and the kidneys are inextricably linked, right? There's a shared pathophysiology when disease manifests. There is, let's see. Here we go, shared risk factors. We know we're seeing the same risk factors in both populations, and we're also seeing them concomitant as well. Diabetes, high blood pressure, inflammation, low physical activity, obesity, and smoking. And so therefore, there are shared disease drivers and shared therapeutic targets. We weren't able to talk about GLP-1 receptor agonists, but that also fits very much so in the CKMH space. So we talked a lot about newer attention being paid to prevention across the spectrum of disease, really for those at risk, those with heart failure. And then this framework, obviously I'm biased, but I really like the fact that we're embracing the fact that prevention needs to be top of mind at risk with heart failure, and then even applicable to those patients who have undergone heart replacement therapies. If I have a heart transplant patient who has diabetic kidney disease, guess what? I'm starting them on finerenone. right? So it's so crucial for us to think of care this way, because I think it'll allow for us to be more proactive with our patients. And again, hopefully you'll all walk away from this session tonight reminding yourselves, remembering when you're in clinic tomorrow morning to check UACR. This is our lane. It is important for us to do that. I loved our discussion earlier on the serial assessment of UACR to showcase to our patients that these therapies are indeed working. And I think it's interesting that people are, as we talk about heart failure broadly, people are saying, well, wow, how is heart failure as a community talking about prevention? But it is so, so true and so important for us to embrace. So some take-home points. Heart failure is stage 4 cardiokidney metabolic syndrome, right? And so we want to be proactive rather than reactive. Prevention is key with risk factor modification, but also applicable once that heart failure diagnosis is made. CKD is represented not just by eGFR, important point. It is represented by UACR. It is a better prognostic indicator for our patients, and we can show them how it improves in response to therapies. Nonsteroidal MRAs represent a class of drugs that remind us of these organ system interactions, and I'm frankly so excited about this space. You saw all the incredible science that we have to look forward to in the space that Muthu showed earlier. And the key is for us to treat our patients holistically and dynamically. So we want to thank you so much for your attention. I want to make sure it's 7 o'clock on the dot, but I want to ask you if you would be comfortable just sharing your question, and then we'll close.
I like very much that you presented clinical cases. You gave a lot of clinical information about clinical variables, and we started to diagnose and to start to select what treatment would be the most beneficial. What I see from the clinical cases, we came with cardiorenal syndrome, which is a syndrome, and primary disease is still unclear. Is it ischemic, non-ischemic, or what other causes? That's why I wanted to ask, do we still have to clarify, is it a cardiac origin of that syndrome or something else? And that's why I wanted to ask you, do we still have to clarify? Because from my perspective and my experiences, we have to do that. That's why I wanted to make sure that audience understands that importance, and you understand that primary diagnosis has to be in this case as well. And other comorbidities also have to be clarified.
Really, really important. And we, of course, did jump to the management side, but the diagnostic step is the very first and most important part, because now we have targetable therapies and interventions for many of the etiologies of heart failure. These are young individuals that were presented in these cases, 50-year-old individuals presenting with new onset heart failure. HFrEF, we are still thinking about ischemia, but we're also thinking more broadly here of genetic or other causes of dilated cardiomyopathies. In a HFpEF patient in their 50s, especially without a past medical history presenting with new heart failure, here you're also thinking more broadly. We learned a lot about that individual. They had a lot of cardiokidney metabolic risk factors that likely did drive her disease process, but in the individual with minimal risk factors, we're thinking about other etiologies of HFpEF, so-called mimickers of disease, including amyloid and hypertrophic cardiomyopathy.
Totally agree with your question. It's a super important point. It's a nuanced point. We, like you said, kind of skipped over it because we wanted to focus on the more obvious medical therapy optimizations. But that patient with the reduced ejection fraction shows up in the ER or in the hospital under my care or in my clinic. They're going to get a right and a left heart cath. I don't want to guess about what's going on with their hemodynamic profile. I mean, I'm looking at that MR, I'm looking at that TR, there's a biventricular component. Patient might be offered genetic testing, to Muthu's point. If I don't find a lot there, I definitely want to define their coronary anatomy. They might be a candidate for bypass surgery if they have 3-vessel disease, and we do have some evidence that surgical complete revascularization is good for patients with that presentation. And I definitely want to understand the cardiorenal component. That said, I still would start my SGLT2 inhibitors before I even get that. And many of my therapies, I know regardless of whether there's cardiorenal syndrome or not, I'm going to be careful and safe, and I'm going to give them the benefit of those therapies.
Yeah, Really great point. Thank you. Andrew Muthu, thank you so much for this discussion. It was a lot of fun. And thank you all for staying till the end. I hope you found it informative.
Thanks.